All right, let's talk about treatment here. I think this is the area that has been somewhat, frankly, depressing over the last several years. I mean, so much has happened in adenocarcinoma treatment with the evolution of, on this slide here, on your left, things like bevacizumab, or known as Avastin, or excitement with just chemotherapies like pemetrexed or Alimta, of course, drugs like Erlotinib and Afatinib, oral therapies that target the EGFR mutation. And then I've talked about targeting ALK and ROS with drugs like Crizotinib, or Xalkori is its trade name. But if we look at the kind of neglected area of this slide, we can see squamous lung cancer is over to the far right. Basically, all we know now in 2013, really 2014, is these patients all get chemotherapy, platinum doublet chemotherapy, not pemetrexed, not bevacizumab, and none of these targeted agents in the absence of any of those targets that get discovered. So a little bit of a disappointing slide. If we look at how we treat squamous lung cancer, early stage, we still talk about surgery. We still talk about even giving chemotherapy following surgery for patients with certainly stage 2 and stage 3 disease. Stage 3, unresectable squamous lung cancer often is treated with chemotherapy and radiation therapy, sometimes with curative results. And then stage 4 disease is really the slide I just showed you, this idea that chemotherapy is the main standard in the world for patients with stage 4 squamous lung cancer, and that really is what gets referred to as a platinum doublet, so a choice of cisplatin or carboplatin. I think that choice has been argued enough, and frankly, I think it comes down to what doctors are most comfortable with. One doesn't appear to be that much different than the other, although carboplatin may be a bit easier for patients. And then married to what would be considered a next-generation chemotherapy drug like gemcitabine or Gemzar or Paclitaxel, docetaxel. We know these drugs as Taxol and Taxotere and Navalbine. And then at the bottom there, just to highlight that it's not pemetrexed, which is Alimta, or not bevacizumab, which is Avastin. And the reason for those statements I'll get to in just a moment. This is where we are with chemotherapy, period, and the idea, well, which regimen should we use, Dr. West or Dr. Spigel, which one is better? And this has now been well studied that any way we mix the modern combinations with platinum therapy, the results are about the same. And I would argue these median survivals are even older than what probably is experienced with modern trials. This trial that I'm pointing to is now over 10 years old. But the idea here is that it probably doesn't matter which chemotherapy doublet gets used. They're all relatively similar, except for toxicities. This is a complicated slide, but if one just focuses on the bottom portion of this slide here, in the bottom left, for example, is what's called the survival curve for patients who receive different chemotherapy recipes. In this case, in the yellow line there, those are patients that received a combination of gemcitabine and cisplatin, and the blue line is pemetrexed or Alimta and cisplatin. And one can see just in this slide in that bottom left corner that the Gemzar or gemcitabine regimen is better than the pemetrexed regimen in patients with squamous lung cancer. So this is the pivotal trial that came out in 2007, actually, that told us that pemetrexed, at least compared with gemcitabine, is not going to be the preferred choice in patients with squamous lung cancer. Now, if you go just above this and look at the patients in the middle on the left who have non-squamous lung cancers, the opposite is true, that patients seem to get more benefit from pemetrexed or Alimta-based therapy than they do from gemcitabine. We now have other studies that have confirmed the role of pemetrexed in adenocarcinoma. Its benefit is greater there than in patients with squamous lung cancer. So this has changed the label in the United States that pemetrexed should not be used in patients with squamous lung cancer. And that's just shown here another way. The other drug, and I just have one slide on this, the other drug that has found its way only into non-squamous lung cancer is bevacizumab or Avastin. And this is kind of a pivotal picture from a main publication now, hard to believe, 9 years old, almost 10 years old here. This was the first study before the major study that got bevacizumab or Avastin approved in lung cancer. But what sometimes gets lost in that whole story of the excitement of bevacizumab in lung cancer is in this early trial where patients with advanced lung cancer were given chemotherapy with bevacizumab or given chemotherapy without, the patients who got chemotherapy with bevacizumab who had squamous lung cancer, there was an early dangerous signal seen in patients with severe life-threatening what's called hemoptysis or coughing up blood. It actually occurred in 6 patients, and 4 of those 6 patients had the squamous histology. And that small signal there was the reason that bevacizumab's development was halted in squamous lung cancer and then allowed to continue in non-squamous lung cancer. So what does that mean? Does that mean that bevacizumab would not help patients with squamous lung cancer? Well, I think many of us believe it probably would help patients, but it may be too dangerous. And frankly, all the trials that have moved forward since then have excluded patients with squamous lung cancer. So right now in the United States, certainly actually anywhere in the world where bevacizumab is approved for lung cancer, it cannot be used in patients with squamous lung cancer because of the high risk of fatal bleeding. Just to mention, there have been other therapies that are here now that do get used in squamous lung cancer, therapies we typically don't think about using in squamous lung cancer. So one of those is Erlotinib. I've talked to you already about the importance of this drug in patients with EGFR mutations. It's worth pointing out, though, that this drug continues to have an approval in patients with squamous and non-squamous lung cancer who don't have mutations after what's called first-line treatment. So said simply, in any patient who's been through chemotherapy and the cancer is not responding and a doctor is looking for a next line of therapy, actually Erlotinib, despite its low, what we call response rate or evidence of its ability to shrink tumors, it is an approved agent, and it is a drug that, if it doesn't cause cancer to shrink, can at least potentially cause cancer to slow down, something called disease control. So it is still a tool in our toolbox for patients with squamous lung cancer, often something that gets, I think, forgotten these days. And cetuximab, otherwise known as Erbitux, a drug that's pretty familiar to patients and providers in the colorectal cancer setting, and actually a drug approved in head and neck cancer. Just want to point out that a large trial was done in lung cancer that showed this drug in combination with chemotherapy was beneficial to patients with both squamous and non-squamous lung cancers, perhaps a hint that squamous lung cancers do a little bit better. I just want to remind everybody that this drug is not FDA approved in lung cancer treatment. It is a drug that is listed as one that should be considered in the NCCN guidelines, but my understanding is this drug does not commonly get used. And it comes down to the fact that this drug was effective in improving survival, but its benefit was thought to be relatively small. And I think that was part of the reason, if not the main reason, this drug has not ever received FDA approval in the U.S. I may skip this part here just to mention some excitement out of one of our major meetings this past summer was the idea that maybe you can do a blood test to decide who should get drugs like Erlotinib or Tarceva. I don't want to get too caught up in this schema here. I'll just let you know that there have been some results recently that have suggested that a simple blood test, and this one's called the Veristrat test, can be ordered in the office, can help us decide who could benefit from a drug like Tarceva. But actually what this slide is meant to show you is that it's probably a better test for telling you who shouldn't get Erlotinib or Tarceva, as shown in the orange curve there. Those patients who have this test done and are scored as poor are the ones who are not going to benefit from Erlotinib. This is kind of a new area. This test has been around for a while. It's been underutilized in the U.S. These data came out at our major lung meeting in Chicago this past June. Kind of a surprise to everybody. I think we're trying to figure out how to digest and use this information and figure out if it's really applicable. Maybe this will come up in the discussion section. One story that's kind of emerged recently is Nab-Paclitaxel, otherwise known as Abraxane. This is a chemotherapy drug that's already approved in the management of breast cancer. It's essentially Paclitaxel or Taxol, but packaged in a way that prevents some of the toxicity and needs for pre-medication that are typical of Paclitaxel and perhaps can improve efficacy. This complicated slide is simply meant to show that in this past couple of years, we've seen news from a large trial in patients with both squamous and non-squamous lung cancer who got chemotherapy with this Nab-Paclitaxel or chemotherapy with Paclitaxel, both in combination with carboplatin. And the trial showed that the group that got Nab-Paclitaxel had a greater chance of the tumor shrinking. So a response rate was higher than the group that did not have Nab-Paclitaxel. Shown on the far left was a pre-planned subset analysis that suggests that this benefit, this ability to shrink the tumor with Nab-Paclitaxel compared with Paclitaxel, was greatest in the patients who had squamous lung cancer. Now, this is a subset analysis. It's not talking about survival, which appeared to be very similar between both arms of the trial. This simply is the response rate. It's an interesting signal. It's interesting that many doctors now kind of think of Nab-Paclitaxel as a squamous lung cancer drug. I don't know that that's fair or unfair. I think that the drug has shown itself to be another active agent in the management of lung cancer, whether it's better in squamous lung cancer or non-squamous lung cancer. I think we don't know from the subset analysis. I know there's ongoing studies or studies in planning trying to further sort this out. A new drug that's now FDA approved in lung cancer treatment as well. This just came out in August. This is a drug, Erlotinib. Sometimes I refer to this as a next-generation Erbitux or cetuximab. I showed you before that that drug was positive in lung cancer treatment but not FDA approved. This is actually Erlotinib, which is another drug that targets EGFR, one of the proteins on the surface of cancer cells, common in terms of its expression in lung cancer. This compound actually being developed by the same company that helped develop and study cetuximab. This is a next-generation version, and this was a large trial looking at the role of this drug in the first-line treatment of patients with squamous lung cancer compared with a regimen that included gemcitabine and cisplatin. This press release came out in August that said that the study achieved its primary endpoint of improving overall survival. This was an exciting step forward in the management of squamous lung cancer. Unfortunately, what all of us are waiting for is what was that advantage. The study met its endpoint. It was positive. That's fantastic news, but we've not yet seen the data. And I think we're all awaiting these data this spring, or early summer, I should say, in Chicago at ASCO is my understanding, and we'll learn more about this, but certainly an early sign of excitement.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.